It's going to be a very stimulating and timely event. My name is Phil Longman. I'm the policy director at the Open Markets Institute, which is co-hosting this event today, and which has long supported the project we're about to describe to you today. I'm also a senior editor at the Washington Monthly, where I've been working with colleagues on this project for more than a decade. We call it the Hospital for America project. In it, we present an alternative way of ranking hospitals, one that accounts not just for their clinical excellence, but also for the cost effectiveness and above all for the institution's commitment to social mission. Let me briefly just give you a few words about how we came to this project so you can have some sense of where we're coming from. For me, the journey began in April of 1999 when I lost my first wife, Robin, to breast cancer. And I never blamed Robin's doctors for her death, but during the 18 months between her diagnosis and demise, I saw one very small but very prestigious corner of the US healthcare system. And what I saw caused me a great deal of alarm and confusion. Every morning when Robin and I would enter the lobby of this renowned institution, we would see a giant poster, blow up of the US News and World Report cover for their annual hospital guide. And this institution was very proud of the fact that US News had honored it with a top ranking as one of the nation's premier cancer institutions. And since I worked at US News at the time and respected the team that did these hospital rankings, I was initially very reassured to have access to this world-class facility. But I noticed over the course of her treatment little things that were quite alarming, ranging from losing tests to losing the patient and other things I won't dwell on, but suffice it to say that it opened my mind to the reality that there could be a large disconnect between the reputation that a hospital might enjoy and its actual performance. That experience led me to an assignment from Fortune magazine, which asked me at some point in about 2005 to write a cover story for them on what they hoped would be an assignment that would lead to my finding what they called the Jack Welsh of healthcare, meaning Jack Welsh, of course, being the storied CEO of the 1990s at General Electric. And so with those marching orders, I went and I talked to a lot of the then leading quality experts in healthcare. It was a budding movement of people in academia and government trying to, first of all, define what quality in healthcare is and then how to measure it. And one of the things that I was initially told by this group of experts was something that just I could not process at all, which was that the early indications coming back were that the VA healthcare system was outperforming the rest of the US healthcare system on many, many key metrics of health, ranging from patient safety to adherence to evidence-based protocols of care, racial disparities, adoption of electronic medical records, et cetera. Meanwhile, another colleague of mine at US News, Shannon Brownlee, was working with researchers at Dartmouth Medical School on what became her landmark book on the problem of overtreatment. And one of the things she was discovering, much to her horror too, was that the hospitals that were highly ranked on the US News list tend to be inversely related to the hospitals that Dartmouth researchers were identifying as particularly egregious in their degrees of overtreatment and other forms of iatrogenic care. So, and then meanwhile, another colleague at US News, who you'll meet in a second, was Paul Glastris, who was on his own journey in beginning to question intellectually how the US News College Guide worked, and the fact that that guide tended to not be capturing a key metric of what we all institutions of higher learning will achieve, which is to create new avenues of upward mobility for those who need it. So that's where we're coming from. It's coming from a long realization that the way that we rank institutions in society really matters. And that if we rank institutions such that prestige and financial resources wind up getting allocated to institutions that put, or away from missions, that institutions that put mission before margin, or idealism and commitment to social justice ahead of maximizing their own pay and perks, that's a real problem. So we spent 10 years trying to figure out how to do this for hospitals. And I think we have succeeded, at least in our first approximation. And with that, I'll turn it over to my colleague, Paul Glastris, who can tell you a bit more about how things proceeded from there.
Well, thank you, Phil. It's a very poignant story. And I too lost a spouse 3 years ago, and had a very different experience, which was, I believe she got phenomenal care at a hospital not even rated by US News, a community hospital. So we come at it from some different experiential points on the spectrum. So as Phil said, we spent a bunch of years in the wilderness trying to get this thing off the ground, and then we had the good luck of Shannon going to work with Vikas Sani over at the Lown Institute, and Vikas will tell you a little bit more about his story when he talks, but they were able to do what we were not, which is put the resources behind creating a system of rankings, which is what we're going to talk about today. And so, you know, we just put this out on the market, published it a couple of weeks ago, and, you know, it just so happens that it's being published, and we didn't plan this, in the midst of the worst pandemic in the history of the United States, certainly in living memory. And the key thing that we've learned about this COVID-19 pandemic is, from the best data we have, and it's incomplete and it's dated, but it looks pretty strong, African-American and Latino Americans are being infected at about 3 times the rate of the rest of the population, and dying at about twice the rate, at least according to the latest evaluation of federal data by the New York Times. A lot of reasons for that we know, but from living in crowded circumstances to being inordinately in frontline jobs where they're more likely to contract the disease. But the care they get in hospitals may be one of them. And another New York Times piece that just came out beginning of the month looked at the wealthy Manhattan hospitals that take care of the affluent versus the safety net hospitals that serve the working class and poor and people of color in the boroughs. And it too found that at the peak of the pandemic in April, the patients at some of these community hospitals were 3 times more likely to die as patients at the medical centers in the wealthiest part of the city. Again, this is all very early. We don't really have strong evidence of causal connection, but it's very disturbing, as it should be. We set out long before COVID to try to figure out which measures would give us a sense, as Phil said, of the fuller spectrum of what we want with our hospitals. Of course, we want quality. We want good patient outcomes. We want low mortality. We want low rates of high rates of safety and so forth. But we want more than that. We want hospitals to be controlling their costs, for the simple reason that healthcare costs have been rising for years for patients with private healthcare at double the rate of wages. And that is a big factor in the devastating amounts and growing amounts of inequality we have in this country. But second, we also know that, as we're seeing with the pandemic, poor Americans and Americans of color have worse health outcomes, and that may be because they are there's differential treatment, that some are going to hospitals that are better funded if they have good insurance, and others are going to hospitals that are less well funded. So we set out to find the hospitals. We don't believe that there ultimately should be or needs to be a trade-off between these three things. We say the hospitals that we're looking for in these rankings, the hospitals we think every American ought to have a chance to go to, are hospitals that save lives, save money, and serve everyone. That is, they have high quality patient outcomes, they control unnecessary treatments, which is a form of spending, and they serve a fair representation of the communities in which they reside. And so with the help of the Lown Institute, we put together these rankings. And I'd like to show you the first one. It's our, we call it our honor roll. And I'm hoping, Kat, you can throw that up there on the screen. These are what we think of as the 20 best hospitals for America. And what they represent, it really is the best in American healthcare. They are hospitals that have better than average, and in many cases, most cases, quite a lot better than average health outcomes in terms of mortality and so forth. High levels of what we call civic leadership, meaning they provide benefits to the community, from free clinics and food banks to other sorts of outreach to the community. They are inclusive, meaning they have high inclusivity scores, meaning that the poor and working class and people of color in the catchment areas of these hospitals are being treated by these hospitals. And we also have a measure of pay equity. The gap between the CEO pay, the top executive pay, and the average staff pay is reasonable. All of these hospitals achieve that. The most important thing I want you to look at and realize is, of our top 20, not one of the US News and World Report top 20 is represented. The US News and World Report is overwhelmingly hospitals you've heard of, world-renowned places like the Mayo Clinic and Mount Sinai and Johns Hopkins. None of those hospitals made our top 20, and they didn't make it, not mostly because they didn't have good quality of care outcomes. Most of them had outstanding quality of care outcomes, but because they threw a lot of unnecessary treatment at their patients, or they were taking in a fraction of the number of poor people or people of color than other institutions. So we think these truly are the hospitals that we all should look up to. And I'm going to ask Kat to show the next slide. We also, again, with the help of the Lown Institute, ranked the 50 best hospitals, the 50 best major teaching hospitals. Some of the good ones, Johns Hopkins and others, comes in at Johns Hopkins comes in at number 10, but there's a lot of hospitals here that aren't as famous as the ones you've heard of. And then the third slide I'd like Kat to show us is we also ranked the 100 best safety net hospitals. Again, these are the hospitals that do the yeoman's work of treating patients often with poor insurance or no insurance, Medicaid and so forth. And it should be known that on the top 20 of our list are a mix of teaching hospitals, safety net hospitals, and community hospitals, small hospitals like the one that treated my wife, Kakula. There are no community hospitals, no safety net hospitals on the US News list. It's all major teaching hospitals. So what do we do with this information is one of the questions I'm going to talk about with the panel. We think there's a lot that needs to happen at the federal level so that we incentivize hospitals to do better by the metrics that we've set out. But the main thing I want to do today is I want to bring to the attention of the audience today several healthcare individuals who I really look up to and who were honored by this, I hope, this award and help this ranking and help make it happen. So let me just go straight to the panel we're going to talk to today. And The first, I'll just read them in the order they're gonna speak. The first is our friend, Dr. Vikas Sani. He's the president of the Lown Institute and the data partner of the Washington Monthly, and a longtime cardiologist. Next, it will be Dr. Kate Welsh. She's the president and CEO of the Boston Medical Center. BMC is ranked #2 on the Washington Monthly's Best Safety Net Hospital list, #4 on our major teaching hospital list, and #10 on our honor roll of our top 20. Next is Dr. Abhijit Desai. He's the chief cardiologist and acting chief of staff at Mercy Hospital West, Mercy Health West Hospital in Cincinnati. Mercy is ranked #5 on our honor roll of top 20 hospitals. And let me also say that we know about Dr. Desai because we found out that about him because his son, Sahil Desai, bragged on him, and Sahil used to work as an editor at the Washington Monthly. So we're so glad that your son made the connection, Dr. Desai. And then finally, we're going to be talking to hear from Robert Early. He is the president and CEO of JPS Health Network. And before that, he spent 10 years in the Texas House of Representatives. So he knows his way around politics too. JPS is the #1 ranked hospital on our honor roll. It's #1 best teaching hospital, and it's the #1 best safety hospital. So we've saved the best for last with you. But let me begin by turning it over first to Vikas, and I'm hoping Vikas, you can tell us a little bit more about the guts of these metrics and what Lown did to create them and therefore and so forth.
Great, thanks Paul. Happy to be here, and good afternoon, everybody, or good morning if you're on the West Coast. I'm president of the Lown Institute, and I think I should start simply acknowledging that at the core of our DNA as an organization is an aspiration to the marriage of clinical excellence and social responsibility. And that really is the legacy of the renowned founder of our organization, Bernard Lown, who developed the world's first defibrillator, and also is a noted humanitarian and social activist, receiving the Nobel Peace Prize for organizing doctors worldwide. I trained with him here at Harvard and then practiced cardiology for about 35 years. I did so both in an academic center at in the Harvard system, as well as in a community hospital on Cape Cod. And I started taking an interest in hospitals, interestingly, roughly the same time as Phil Longman described in his story, which was in 1998, because I was negotiating risk contracts with all the Boston hospitals, except actually Boston Medical Center. And in that process, I learned a lot of the variability that hospitals had. And around the same time, my friends at Aspect Medical Systems, a company I had co-founded for medical devices, started looking at hospital profiling and developed a new tool called the Risk Stratification Index, which we began to examine. So when I returned to Harvard from my community practice, it was kind of natural for me to start exploring a number of different ideas. And I'd say it's a fair comment to say that it's my kind of very unique perspective from different sectors and stances in healthcare that made me recognize we really need something better. And so our overarching objective as we created these metrics was really to create a new lens, to think differently about what we know and what we need to know about healthcare in order to be able to truly measure all the performance that matters. And so first out of the gate was really the issue of overuse or low value care. And that's in part because that's been a long-standing interest of mine derived from Dr. Lown. Bernard Lown was a famous skeptic about the merits of bypass surgery and stenting in anyone except the most serious cases. And I took that with me in my work. And when I returned to the Institute, I teamed up with Shannon Brownlee, as you heard Paul mention, and we put on an early conference called Avoiding Avoidable Care that was seminal in many ways. But after raising the issue, we recognized without tools to measure, it really was not going to advance further. And so that really was how we started thinking about new metrics for a new comprehensive index. And so we knew that this index wouldn't yield the usual suspects, but honestly, I didn't really understand, and we didn't realize how high the bar was that we'd set. And I'll say I was actually quite taken aback when we first started seeing the results that we were seeing, because many of them were quite counterintuitive. So let me just state, the central finding that I see in our work, which Paul sort of alluded to, and that is that there's really a kind of major disconnect. It's a tale of two cities, if you will, when you look at traditional clinical metrics like mortality and readmissions versus some of our newer measures that we developed at Lown, inclusivity, community benefits spending, and pay equity. Combining these into a single measurement was very ambitious, perhaps a little naive, although entrepreneurship has taught me naivete may be the greatest strength, and the challenge to reconcile clinical outcomes with social outcomes. So I think it's important to point out a few things about this major disconnect. I think most people, including many doctors, probably don't know that medical care counts for maybe 15 to 20% of a fraction of the total factors that determine life expectancy. And that's all medical care. That means visits to the doctor, medications, surgeries, all of it. So visits to the hospital are only a fraction of that fraction. So it's important to keep that perspective, because when we look at clinical outcomes like mortality, and we report them, all ranking systems report them, and other ranking systems tend to report them preferentially. It's important to recognize that those mortality rates carry some effect from the hospital care, but they also probably carry a whole lot of social determinants. Risk adjustment tries to even that playing field, and we think risk stratification index is best in class, as good as any that are published. But at the end of the day, none of them can completely capture some of these underlying tendencies, which is to say, it's probably the case that much of the good mortality and much of the bad mortality of different hospitals is attributable to hospital care, but how much is highly uncertain. And it's also quite possible that some of the credit or some of the low grades are really not of the doing of the hospitals. It's an important perspective. For us, as we put these metrics together, I think the biggest challenge was really the data, the availability of it, the sort of processing of it. And in particular, an area that is a big gap that I want to point out is we used Medicare data. We really wanted to use commercial data, but when we searched and found certain data sets that were available, the ability to actually measure and report the value and any meaningful definition of value would include some aspect of the pricing. That, excuse me, was completely not available. It was not on offer. So that's a problem with ours and any ranking system to date. I think it's deplorable. It's an area that ought to get fixed, and hopefully it will. Just a few last comments. The data on community benefit, that we report is a subset of everything that's available. We made a call about what is meaningful. Now, community benefit is an IRS tax exemption. The reporting is highly variable, and there really is and should be a robust debate about what those elements are and which of them truly benefit a community. So we hope we're going to help trigger that debate. Our inclusivity metric is really, my view is it's just the first attempt. It was something we came up with at Lown. All keen observers of the American healthcare system are aware of the underlying reality, a kind of de facto segregation that Paul alluded to. But when we did this, our goal was really to create a tool to maybe quantify in a way that would be useful as we monitor improvements and navigate our way to a new healthcare system, a healthcare system of the future that may get around some of the serious inequities in race and class. And lastly, pay equity was quite a heavy lift for a small organization like ours. And here too, our core view was that it's important to start the conversation. Larger hospital CEOs make more money. And to some degree that makes sense, because it's almost certain that it takes a lot more energy, time, and talent to run a much more complex organization than a simple one. But really, we found as we look through these rankings, some questions about how much is reasonable and what kind of complexity and how much of the social good is met. So the variability in pay equity is also something we think is a conversation that needs to happen. A few simple technical notes, because we've been asked some of these. We use hierarchical regression models. That's exactly the way CMS and the Yale Outcome Center assess hospital effects. We did include some non-standard outcomes like 90-day mortality and 1-year mortality, as well as 7-day readmissions. And these are all things we're happy to discuss and debate. We are preparing a lot of peer-reviewed papers that'll have plenty of those details. And in the end, probably the biggest technical challenges we faced was creating comparable ranges of the variable scores for what are otherwise very disparate variables. But as I said, our ambition was a global metric, a 360-degree view, and we felt it was important to combine these two types of metrics in the way we did. We think this is a first iteration. It's going to take a lot more time, effort, and resources to really perfect this, but we believe this is directionally right, and the overall objective is absolutely worthy of a national goal for healthcare in our country. So I'll stop there.
Thank you, Vikas, my friend. Next, Kate Walsh, CEO of Boston Medical Center. Kate.
Hi, good afternoon, everyone. Thank you. On behalf of the 6,000 people who work at Boston Medical Center, I really want to thank the Lown Institute, the Washington Monthly, and the Open Market Institute for this recognition. Our health system's about $4.9 billion, and it's comprised of our academic medical center. We're the primary teaching affiliate of the Boston University School of Medicine. There's over $400 million of peer-reviewed research on our campus each year. And one of the things we should talk about is the role of innovation against some of these social determinants that Paul outlined. We also own and operate Boston Medical Center Health Net Plan, which provides peace of mind and access to healthcare to over 400,000 Medicaid recipients across Massachusetts and New Hampshire. So that's another interesting feature of our system. And we're privileged to work with over 14 federally qualified community health centers in our region. They're kind of our network of providers. So I would be remiss in taking this bow on behalf of our system when not acknowledging our health center partners who have been such an important part of our work. Over 70% of our discharges and patients identify as people of color. 50% of our patients live at or below the federal poverty limit, and about a third of our discharges are translator assisted in some way not just medical encounters, I should say, are translated assisted in some way. We're in Boston, obviously, which is home to, as we said in the opening, some of the best and well-recognized hospitals on the planet. So this recognition is especially gratifying for us. I was asked to speak a little bit about like how we put this together and why we think we landed on this list, which I don't want to poke too much at because we might get kicked off, but I think it really does go back to our history. And we were formed by the merger of then Boston City Hospital, which has had a long and distinguished history in American medicine, and University Hospital, which was the private teaching hospital, if you will, of the BU School of Medicine. That merger happened about 24 years ago and put together Boston Medical Center as a 501c3, like any hospital you might see around the country established for a charitable purpose. But we had those city hospital roots that kind of grounded us in our mission, which is to provide exceptional care without exception. And I think that we live our mission every day on our campus, and it's as simple as everybody is welcome on our campus, and we take care of people regardless of their ability to pay. And as complex, I think, as some of the programs and services we've built to help our patients get healthy and stay well. We are 15 plus years into a therapeutic food pantry on our campus. So our physicians and nurses can write prescriptions for food like you'd write a prescription for insulin. We think this destigmatizes hunger, which is a challenge in our country. We have food, we just don't have safe and effective ways to distribute it. It also connects people it creates a connection between proper nutrition and good health. Our food pantry provides a 3-day emergency supply of food for your family, for your household. So it also addresses the kind of hunger we see in this country, which tends to be episodic. People run out of benefits at the end of the month, somebody loses their job and are couch surfing on your couch. So we've really created at least one plug in a safety net in our country that's increasingly frayed. we are very proud of the work that we do in addiction services, and actually have received a significant philanthropic gift from the Graken family for a $25 million gift for our Center for Addiction Support, which is for addiction medicine, which is really kind of unheard of. We didn't see any gift of this magnitude directed at the opioid crisis. And it was at a time when it was really a major challenge in our city. It's still a major challenge in our nation, and bringing to bear both strong clinical services that are kind of mainstreamed into our primary care practices, but also academic and research underpinnings to solve the disease of addiction like a disease, not a moral failing, I think is a real strength of our organization. Similar programs are on urban violence, and we took the unusual step of making what I think of as an upstream investment in the health of our patients by, we have 5 different housing experiments underway in the communities we serve, which range from actually buying and retrofitting units for people who are very hard to place to putting grab bars in public housing authorities so people can go safely back home, and everything in between. And I mention that because, when you run a safety net hospital and you're making investments in housing, people kind of look at you a bit askance, like, why are you doing this? And it really comes down to the fact that one of the most important things we can do for our patients is make sure that they have a safe place to shelter. This was driven home during COVID, where we spent a couple of many sleepless nights trying to figure out what we would do if this pandemic really took off in the congregate shelter population of the city of Boston. So we spun up a COVID recovery unit, which I think was a great addition to our ability to care for patients. 80% of the people who catch this disease need to isolate, and most of us can isolate at home. Chris Cuomo isolated in his basement, but what happens when you don't have a home? So we were able to create a safe and therapeutic environment for people who were housing insecure, homeless, or lived in multi-generational housing and simply could not go back home. I use that as an example because I think the other thing that COVID drove home, and it's been alluded to by the 3 previous speakers, is really, it really drove home the impact that racism has on equity of healthcare in our country. And even at a place like Boston Medical Center, where 70% of the people we serve and 50% of the people who work here identify as a person of color, we know that racial inequities are, if you will, the next frontier that we need to crack as if we're going to get to the top 10. But I think that part of our work as an organization is really to have that conversation, have that dialogue, and have it in a way that's aided not only by well-meaning people, but backed up by an academic and rigorous approach that improves the quality, not only the quality of care we deliver, but the health outcomes of the patients that we serve. So I'll leave it there.
Thank you, Kate. That was a terrific narrative about how you managed to do what you did. A lot of interesting material that I want to ask you more questions about. Dr. Desai, I would love to hear more or less the same from you. How did Mercy West in Cincinnati, a hospital I think a lot of people in Cincinnati are not too super familiar with, certainly I wasn't. How did you manage to save lives, save money, and serve everybody and score so high on our rankings?
Well, I just wanted to thank Washington Monthly, Lown Institute, and Open Market to invite us for this interesting webinar forum. I really appreciate that. I think as a cardiologist, my journey about this thing is quite interesting. We are located in the southwest corner of Cincinnati, where our hospital is located at. And the southwest corner, or the west side of the Cincinnati, as we call it, is very unique in the sense that, we have predominantly about 70% of our population is Caucasian, about 24% is African American, and rest of us are the immigrants. We Indians are everywhere. I'm sorry, but we are. What can I say? And 10% or more of our population live below the poverty line. So, and it is very unique in a sense that the west side of Cincinnati, the people who live there, they are wedded to the West Side. They have lived there for generations. Even if they go out of Cincinnati for further education, they come back to the West Side to grow and raise their family. So on the West Side, when you are asked, what school did you go to? You don't say, I went to Harvard or I went to Mayo Clinic or wherever. They want to know what high school you went to. That is more important to them than going to any of these Ivy League schools, for that matter. So that's how they are absolutely very, very wedded to their West Side roots, for that matter. People are, it's like a big family being in the West Side of town. People know everybody, and just people really like to be staying there, getting their services there. So when I joined as an interventional cardiologist in 1991, there are two little small hospitals on the west side of town which were providing very basic needs of the community. And I quickly realized that, well, wait a minute, this doesn't make any sense. As a cardiologist, I'm not able to do any of these patients who need either the stents or the bypass, or if they come in with an acute heart attack or STEMI as we call it, we can't provide those services. And I had numerous conversations with my administration over the years without any success in trying to have those services available to us. Fast forward 1999, when Mercy System bought these two hospitals, they still were not able to provide those services for quite some time. In fact, I took myself along with my partner to do some angioplasties and stents without any surgical backup, which was acceptable at that time in Ohio. We had a great success, and we saved number of lives and number of heart muscles. Vikas would know what I'm talking about, as a cardiologist. But that did not go any far because people wouldn't come to our hospital. So one fine morning in 2010, 2011, we got a call from the Mercy administration that we're going to build a brand new hospitals on the west side, and we're going to provide all the services that you all have been asking for. And that came as a very big surprise to us. And Mercy administration was nice enough to be the physicians in the service line development. And came 2013 when we opened the door to this hospital. Now, our goals were very simple. What we had decided that we are going to provide evidence-based medicine to all of our patients, regardless of their socioeconomic status, regardless of their race, regardless of their ethnicity. We want to do what is best for our patients. And that's all we worked on, and we worked tirelessly to make that happen. So, and when we opened the hospital, obviously we're not going to get all these people to us. And in fact, I was quite shocked when I was involved in this process of developing this service line. The 65% of the population of the West Side, mind you, these West Siders want to have things on the West Side, I told you before, but they were not getting the care. So they were completely bypassing these two small hospitals, going further east for their care. So I said, that is unbelievable. So I said, we have to work extra hard. We have to earn the respect of these folks and have them come to our hospital. So we opened the door, and obviously, by just opening the door and having a beautiful facility is not going to get people inside the door. So we gradually built ourselves up. Our volume slowly but steadily started increasing. We made sure anybody and everybody who walks into those emergency rooms or to our doctor's offices will get the same care, whether they earn $100 a week or they earn $5,000 a week. They will get the same quality of care. We will not overtreat them. and we will make sure that we have the best possible outcomes. Yes, we had challenges, but we overcome those challenges and continue to provide that care. And we realize, just like what Vikas said earlier, in this whole process, I know for a fact that we, the physician, the healthcare system, play a smaller role. There's a role of the socio-economic challenges that people have. They cannot afford their medicines. They don't have anybody with them in their houses to take care of them. They don't have the loved ones like we all have to take care of them. So we need to make sure that we as a system extend those kind of facilities or the benefits to them. And that's how we created this network. We have this amazing quarterly health fair that we do in our hospitals, where we educate our population about benefits of eating healthy, exercising regularly, making sure that they understand that disease is proper. And this is what will lead to a better outcome in a long run, just like what we are seeing now with this COVID epidemic. I think, to me, I would say we are, as an American health system, has been found naked, honestly, by what we see. I mean, the rest of the world is able to contain this epidemic, but we are not, because we don't have an adequate public health awareness that we need to have to contain this. And this is not related just to the COVID. It is really coming down to, when we do things right, all the chronic diseases that we treat, we can have a better control on taking care of our patients. And I just like to personally share my own accolade, if I may, that when we developed this hospital, we wanted to have a heart failure recertification. And I think Vikas would know more than anybody else. It is a very raging increasing problem as population is aging. People are having a bad heart. They cannot, take care of their heart failure. And we developed a very comprehensive program, including our community in it. And we have gotten an advanced heart failure certification. We are the first Mercy to do so. And we have continued to do well and have developed this recertification. So, and we have had numerous other accolades, including stroke prevention certification, joint certification, etc. So I like to really, truly want to thank, this is a collective effort from all the employees. Unfortunately, I don't have the exact numbers of employees my hospital is. I'm sorry about that, but I think including the janitor who works in our hospitals to the CEO of the hospital, all of them get the credit for what we are. And I really, really appreciate that we have been recognized by, not that that was our intention. Our intention was to do what I just talked to you about. But, it has been recognized by this wonderful system you all have developed. So I will stop here and thank you for letting me share this with you.
Thank you very much, Dr. Desai. And now I want to ask, again, more or less the same question of Dr. Robert Early of JPS. You hit number one in all three categories, Doctor. How did you come, what was this conscious? Obviously you didn't know we were going to measure this, but what is it that you've done over the years that you think contribute to your being able to both have excellent health outcomes, controlling overspending, and treating your broad section of your community down there in Fort Worth?
Well, Paul, first, thank you. Thank you very much. We so appreciate it. There's 7,200 of us at JPS, and JPS is probably not the name that any of y'all heard about. John Peter Smith was the first mayor of Fort Worth, and that's how we got our name. We've been around for 115 years. So we've been doing this for quite a while, and to get recognized for it by the Lown Institute and Washington Monthly and Open Markets Institute is just such an honor, particularly in a time where people are weary. It's hard to get up and come to work no matter what your heart size is, what your mission is. And to get an honor like this is quite a boost. So we're excited. A little bit about us in that we are the only level 1 trauma center. There are a variety of them in Dallas, but in Tarrant County, which is right next to the Dallas area, we're the only level 1 trauma center between Fort Worth, Texas and Lubbock, Texas. And if you look on a map, that's a long distance, and there actually are people that live between Fort Worth and Lubbock. We know them all on first name basis, but there are people that live out there. And we are their level 1 trauma center. We're a teaching hospital. But to answer your question, Paul, as to why and how, we really go back to the basics. There are 3 basic rules to work at JPS. And if you work at JPS, no matter what level you are, from neurosurgeon to environmental services superhero, you got to follow these rules. And rule number 1 is you own it. And when you talk about owning it, you talk about accountability and responsibility. It makes people be everything that we do. Everybody's a part of it. We have 3,000 nurses, but in all honesty, everybody's a nurse. We have incredible neurosurgeons, but everybody's a neurosurgeon, because when there's victory, we all take it. So that's what ownership means. The second quality that we have is, second rule is, you must seek joy. We had 1.2 million patient encounters last year. And what we tell everybody at JPS is anybody that walks through our door, in all likelihood, is having a worse day than you. They're scared, they're fearful, they're hurting. We have to tell them the pain in their stomach is cancer. It's a hard place to be. So we need to smile. We need to smile. We tell everybody at a minimum, you have to smile once in your day. And if you feel a smile coming on and you need to Google that feeling because you've never had it before, we will need you working at JPS. In fact, we're going to ask you, if you can't smile once in your day, we want you to be part of our community relocation program, because we don't need you. And rule number 3 is really straightforward and really simple. Don't be a jerk. We don't like jerks. We don't like people who resolve their challenges and their problems with screaming and yelling. We don't like throwing of things. We don't like that kind of attitude. So we've got 7,200 people all moving in the same direction. And when you have a COVID-19, everybody moving in the same direction is powerful. When the other thing is, and Dr. Walsh talked about this, I'm so impressed with Dr. Walsh and her team, because we've seen—
By the way, not a physician. My husband, who is a physician, says I know enough medicine to be dangerous. But I thought I'd clarify that for the record. But
you could be Mrs. Walsh, and I'm Mr. Early, because my wife's a veterinarian and she's the smart one in the family. But one of the things that we watched about you all up there in Boston was that very thing. We partnered with, we were just about to unroll it when COVID-19 hit, but we partnered with a great group out of California called Hunger Not Impossible. And what we're trying to do is take our diabetic patients and feed them 3 times a day. Mm-hmm. We want to look at that case study and realize, if we feed people 3 times a day, and not eating kale 3 times a day, not eating the best of food, just taking our patients that currently live in a food desert, who are economically deprived, if we feed them 3 times a day, can we reduce their H1C1? Can we get to a point where we are combating the diabetic issue, as opposed to come in, take your meds, and go home? We're probably one of the few institutions, and many on y'all's list, and that's why I'm so impressed with y'all's list. So many people on that list. We're the only institutions in America that actually want less patients. We don't want our beds full with patients. We want to get out of episodic care. We get 400 people a day in our emergency room. I don't want 400 people a day in our emergency room. Many are using it for primary care. And in order to have a primary care effective system, you got to make it convenient. You got to change lifestyles. And that's what we try to do at JPS, is change lifestyles. So I will tell you, and Paul mentioned it, I am a recovering politician. I used to be in office. I was in the Texas House of Representatives. I spent 11 years there, from 23 years old to 33 years old. And it was a great experience. But I'll tell you, real politics exists in healthcare. The legislature were minor league players to what real politics is. And it's the disparities at which we see and how we need to solve them. And JPS and being a part of healthcare has changed my life. It's made me a better person. It's given me the ability to understand people, their harshness, their realities, their sadnesses, and their joys. And to your point, Paul, we do everything possible to make healthcare the human side of healthcare. If I have a CFO and they cut $10,000 out of the budget, they better come into my office and tell me the impact of $10,000 reduction. So we hire people at JPS who have a heart and a mind to healthcare. Because in healthcare, if you only have a heart, you go bankrupt in 1 month. If you only have the mind, you're only thinking about a profit level. And that's why y'all's honor of us and everybody else who's on that list, we're happy we finished first, but quite frankly, we're just happy for the recognition. You all afforded us a luxury to tell people, you see, this is what we've been doing, and this is why we get up every morning, why we go home and get up excited the next day to come back in. So thank you all. I couldn't be more honored, and I represent 7,200 people who are collectively turning your way with joy and excitement because you honored us. Thank you.
Thank you, Mr. Early. I really do appreciate that. That's sort of why we got together to do this, to shine a light on these sorts of extraordinary hospitals. And, you know, as I said, it is hard to find hospitals that hit the high marks on all three of these save lives, save money, serve everyone metrics. But part of the reason we did it is because we thought if we can show that it's doable, then it becomes a goal that other hospitals can try for. But, you know, you being a politician, you understand that there's a political and economic superstructure that can incentivize hospitals to try to be like you all or to not care about being like you all. And so, you know what, OMI and Washington Monthly, we're policy organizations. And I want to turn to Phil for just, you know, I want to get to some questions from the audience. We're going to go, by the way, a little bit over the hour here that we said we were going to be, because we do have so much to talk about. But, you know, how do we, you know, the question we would ask is and I would love to know the gang's thoughts about it. But first, Phil, what are the policies that we can get out of Washington that would lead more hospitals to take a chance on trying to achieve this sort of triple crown of success that you all have had? Phil, you know, I kind of know you're thinking about it, but give us your thinking about it, because the audience doesn't. What do we need done? We've got probably another bailout coming. We've spent $100+ billion on hospital bailouts. Another's probably coming. What can we attach to that bailout in terms of strings that would incentivize hospitals to be more like these guys?
Well, that's certainly the moment that's coming relatively soon, because the COVID crisis has had the effect of severely damaging the finances of many hospitals. And we are definitely going to need another round of big bailouts. But while we're doing that, why not think about what kind of conditions we might want to put on those bailouts so that they go to the kind of institutions that actually do serve the public best. And so I would think that there's an opportunity to in that context, to look at some of the metrics that we've developed here. In that context, another policy lever that's out there, it's being used at the state level as well as the feds, right, is most hospitals, including highly profitable hospitals, are officially nonprofit hospitals, and they enjoy nonprofit tax status from the IRS. And in return for that tax status, tax subsidy, they're supposed to give all kinds of community benefit. But as we've heard, in the real world, most don't, or the reporting of their community benefit for IRS purposes is sloppy and largely fictional. It's also true that many institutions you know, our state chartered charitable institutions. In this current issue of the Washington Monthly, I have a piece, and we take a long look at the University of Pittsburgh Medical Center, which is an august institution in its origins. As you know, that's the institution where the polio vaccine was pioneered back in the 1950s. It's a chartered under the state of Pennsylvania as a charitable organization, and yet it has evolved into a profit maximizing institution that, as you can see from my article, is anything but charitable, and many of the things it does. So the Attorney General of Pennsylvania has been able to use the fact that they have this state charter and are responsible to it to jawbone them into some kinds of more responsible behavior. But every Attorney General in the country also has similar powers. I would just say briefly too that you know, we need reform of the payment system so that when you do have a system in which you're treating diabetics by buying them three square meals a day, that you get paid adequately for that. And unlike today's healthcare reimbursement system, in which basically no good deed goes unpunished, right? Because the reimbursement rate is a reimbursement system overcompensates specialized care and undercompensates preventive and primary care and care coordination. And then finally, I would just say too that again, in the current issue of the Washington Monthly, I have a piece in which I make the case for why we need transparent, uniform, administered pricing, because right now we have a system where there's just rampant price discrimination between patients and other payers. And so there's really no relationship at all between the prices of services and the values of services. They rather reflect monopolistic power balances. And so basically every other industrial country in the world, whether they have socialized medicine or not, you know, has transparent prices set uniformly by some kind of disinterested price setting body. So those would be my big three policy levers. And you know, some of us have been in this space for 20 years and never seen the opportunity come along to do actual transmission work on the healthcare delivery system itself, as opposed to healthcare finance. But I think the moment, because of COVID and because of the extreme financial meltdown that the healthcare system is looking at, the moment is coming that we can actually get into the crankcase here and do some real improvements.
Well, let me pick up on that. And I know that the hospitalists here are not policy people, but I do want to get your thoughts quickly because we don't have a lot of time. What do you want to see from Washington that would make it easier to do what you do and might encourage some of the other hospitals that you know of to do more of what you do? And Robert, Dr. Desai, Kate, Kate, why don't we start with you if you've got any thoughts on that?
So yeah, I have three things to add to Phil's transmission work. One is preservation of 340B, which is it's a slightly wonky program, but the pharmaceutical industry hates it. It basically allows us to acquire medicines at a wholesale price that the federal government acquires them at, and offer. And so 340B has really enabled our organization's ability to provide medicines. We do about 3 million prescriptions a year on our campus. About 1 million of them are quote unquote free. 340B enables that. Second thing, we saw, because of COVID, a major increase in telehealth. We weren't sure what it was going to mean to our patient population. It has been a game changer, and reimbursement for telehealth has to stay. So as there's, you know, I think the health insurance industry feels that they can't, I don't know what they feel, but that really is incredibly important, particularly in the places where people need services the most: behavioral health, substance use disorder. It's absolutely a game changer. Third is we're going to spend $26 billion in COVID research. This is a disease that has disproportionately affected communities of color. We need to make sure that those medicines, those trials get to those communities. There has to be a legislative way to ensure that that occurs. And then finally, the next $60 billion that's distributed, it should go to the communities that were most affected by this, because rebuilding those communities is going to be essential to rebuilding the health of the people who live there. So I'll stop.
I think also, Paul, one of the things that we need to realize, and I realize this in legislative circles, is bad debt is not charity care.
Right.
And amazing. I hear a lot of folks go, "Oh my gosh, we're getting paid 40 cents on the dollar."
Yeah.
Well, Mercy in Cincinnati and the folks at Boston Medical, they're getting paid 0 on the dollar. And it's really when you go up against all this and they say, let us tell you legislators and legislative bodies throughout the state what our charity care is. No, that's your bad debt, and that may be bad business, and that may be how you do business, but it's not charity care. The other thing that I think, and I hope the federal government would do, is base their reimbursement dollars on outcomes. Make us tell them, if you provide us X amount of money, even before you provide it, I'm going to go and do that project, get the outcomes to better health, then you reimburse me. And to Phil's point, I'm not going to get any money out of feeding people 3 meals a day, but it's the right thing to do, and we will do it. And to Kate's comment about telemedicine, it's been a game changer for all of us. And if they fund it and quit listening to those that say don't fund it, you'll improve people's lives.
Well, can I say, I think the other thing I like to see happen, I think the whole concept of fee for service needs to change, quickly. I know we should be compensated for preventing the disease and its associated complications, as opposed to being, if I'm getting paid for my angioplasties and stents more and more, I would have an incentive to do those procedures more. But if I can really teach my patient to eat properly, eat these 3 meals if he's diabetic, if they reduce the salt in the diet, they exercise regularly, and if I am able to prevent that patient from coming to me and having their angioplasty or bypass, I'm doing that patient a favor, I'm doing a healthcare a favor, and I think we should be compensated more for this kind of things, as opposed to, and we will save lots of dollars to the healthcare. I think the healthcare costs cannot be sustained with what we are doing. And I think this epidemic has again proven that people with chronic diseases are the ones who are getting affected the most, obviously, and that comes down to the racial inequality, where people with African American origin have all these diseases because they are, not being taken care of. They don't eat properly. We need to educate them. We need to do a better job of doing these things, and that's how we can curtail the cost and provide a better care. And I mean, compared to the rest of the world, we are not doing that good of a job, even though we have all these fancy gadgets to treat the diseases. And I think that should be the reason that we need to work very hard towards achieving these goals.
Dr. Desai, it's a pleasure to hear an interventional cardiologist take that position. Let me just add one thing to what Phil and Paul said in the premise. I think it's also useful to think about the premise itself, which is this kind of accountability, with what can we attach as conditions to the bailout. We need to think about how to structure that not as episodic accountability, but as continuing accountability. I mean, I think from the Lown Institute point of view, that would be a central message for us, which is there's a lot of scope for a lot more democratic input into how the healthcare system is designed and how it's governed. So.
Well, that's a great point, Vikas, and I think it's worth stressing. We are aware from the protests over George Floyd to the stresses put on the public health system, or the showing of the hollowed out public health system. We're coming to a point in this country where we're going to see, everybody's kind of recognizing we're going to see some major structural changes. I don't think most people have quite internalized how much of that has to come into what Phil called the healthcare delivery system. A lot of the debate's been on making sure people have insurance. What this product, this process that we've been through with these rankings show is that in the delivery of healthcare, at least at the hospital level, there are these tremendous disparities when it comes to treating people equally and well. And so, if you think about the 4 or 5 things driving politics right now: inequality, the recession, COVID, racial justice. They all come together in hospitals and in healthcare. So look, let me just throw a few more questions at the gang here from our audience. We don't have a lot of time for this, but there are a few that I think are really worth asking. One is, how does one evaluate community benefit as it has been also used as a tax write-off at a time when most states' hospitals have expanded Medicaid coverage through Medicaid Obama expansion? And how do we best evaluate nonprofit hospitals that maintain huge reserves? Vikas, I'm going to ask you that question. I think what they're getting at is, and we've alluded to it, and Phil has too, the actual community benefit database that we have to use to do this sorts of thing is pretty flimsy, and one has to be very careful what one chooses to put in a ranking like this. How did Lown navigate that, and what needs to change in terms of how we report community benefit?
Sure, I'll try to be brief. 2 big categories that we decided not to include. Actually, I should say 3. One is the one that Mr. Early pointed out. We don't really look at Medicaid shortfall as a community benefit. We also don't look at research as a community benefit, and not that it isn't a laudable and lofty goal, but I think there are real questions about who funds research, what's the governance and accountability, especially if you're aware, as I am, that a recent global study on research and waste in research estimated that over 80% of what is done in research is poorly designed, inadequately reported, and not directly material to the facts. So I think communities have a role to question that. And third, we did not include health professionals training, which is a whole big conversation. The reason we didn't was because many institutions are compensated, certainly by Medicare, both for the health professionals training explicitly, that's the so-called direct payment, but also in a bump up of their DRGs, that's the so-called indirect. Again, it's all debatable, but I think the real question, and I think where we are, and like so much else, this is a recurring theme. I think what COVID has shown us is it's time for a reboot. It's time to look at all of these. And in particular, I think the real missing ingredient in the IRS and community benefits reporting is the lack of a closed loop in which there is some evaluation of the actual reporting, and after the reporting, some assessment of to the extent to which it actually meets community needs. All of that needs a refresh.
Thank you, Vikas. Let me ask one more question, and I think this can go to anyone in the group, but I know Vikas has thoughts on this. The data on patient satisfaction as a measure of quality of care is very mixed, and studies suggest that higher satisfaction is correlated with worse outcomes and more spending. Why did you include it? That really is a question for you.
Yeah, so I'm happy to take that one on. What we've seen with patient satisfaction is, in fact, that there is an inverse correlation between patient satisfaction and mortality. This is some of the work we'll get out in peer reviewed. So I don't dispute that fact, but I think that it's not so easy to decide what that means. So for example, what we see is that patient satisfaction is high in smaller hospitals. It's high in rural hospitals. It's not high in big hospitals, including big urban hospitals. What that means is that there's probably something about patient satisfaction that may be sociological, cultural, or regional. Mortality is the opposite, and some of that is understandable because every time we've looked in medicine, when you do high volumes, when a surgeon does high volumes, they tend to have fewer complications. So smaller hospitals, and this has been an area we've been looking at carefully, rural hospitals, critical access hospitals may well have higher mortality. The question is, are these two things true but completely unrelated? My view is they probably are. But the challenge for all of us is how to achieve high satisfaction in big institutions when human beings are not wired for big institutions.
Yeah.
Yeah. Phil, can you give us just 30 seconds of summing up here? Because we have gone a little bit over our time. We want to do this again. As Vikas said, this is a first pass. We think it's directionally correct. We stand by what we're doing, but there's a lot more that we want to do in future iterations of this. Give us just a sense of why this exercise, is one that we wanted to do so badly for so many years and really is worth kind of doing in the future. What more do you want? Is this more than just a one-time like snapshot?
Well, I think it's very important in every realm of life, but also in healthcare, that the people who are doing the right thing are recognized for doing the right thing and compensated for doing the right thing and not punished for doing the wrong thing, right? I spent a lot of time writing a book about and spending time with people that work in the Veterans Health Administration. And part of the huge problem that they have is the total lack of, well, not total lack, but the terrible reputational problem that the VA has in the press, which means that folks that work for the VA go home to Thanksgiving and have their relatives mock them. And that's terrible. I feel good about maybe telling some stories about VA healthcare that reinforced the nobility and the excellence of many of the frontline workers at the VA and what they were doing, right? I hope that this exercise is the same in that, at the very least, it helps build morale for the people who, as we speak, are in emergency rooms dealing with unbelievably stressful conditions, and gives them the acknowledgement that we know what you're doing, and we recognize it, and we want to draw attention to it. So that's the first thing. And after that, I think this can be a mechanism for changing the frame of discussion about healthcare reform, so that instead of concentrating entirely or almost entirely on healthcare finance, Medicare for all, or various other proposals for jiggering around with finance, that we're concentrating on the actual delivery system of healthcare and doing it in a way that maximizes clinical values, right? But also social equity, social justice. And that's, I think, what most of us want from our healthcare system, right? We want doctors who know what they're doing and are good at what they do clinically, but also institutions whose purpose and performance is aligned with the public interest, the broader public interest. So that's my hope of what we get. And I'm so thrilled that we've at least been able to come to this point. And I do hope this is just the beginning of an ongoing process in which every year we build and improve this ranking.
Yeah, I'm with you, my friend. So a salute to the panel that has kind of shown us what the best healthcare in America, the best hospitals in America are made of. And as Phil said, I think we hope that this recognition is something that, and I'm hearing that it is something that you appreciate and you haven't gotten enough of. And our aim is to give you more of it and have more people recognize the great work you're doing. So thank you to the panel. Thank you, Vikas and our friends at the Lown Institute. Thank you, Phil, at Open Markets Institute. And we'll hopefully see you all next year at about this time when we do the second one. Okay, take care. Thank you, everybody.
Thank you very much.
Thanks, everyone.
Thanks for having us.
Bye-bye, everybody. Thanks.
Bye.
Bye-bye.